Now we're going to discuss the high-risk chief complaints in regards to neurological issues. Again, this is a very broad category which involves many issues. So what we are going to discuss is the three major ones. And as I just mentioned, there's many issues with neurological issues, which could also include altered mental status in that category or even a headache. But the goal is to use the systematic approach to narrow down the differential diagnosis and looking for those red flags that let us know if it's an immediate life threat. Ischemic strokes. We put a picture of a dam here because it's a good conceptual representation of what is happening during an ischemic stroke. When we talk about strokes, that term itself is very vague. As you can see from the slide what exactly the word means. Stroke and CVA are interchangeable terms. From this definition, technically a TIA or transient ischemic attack could also be considered a CVA since there's no length of time for the blockage. We'll go over ischemic first, not surprisingly. Risk factors for ischemic cerebrovascular disease parallel those for atherosclerosis. Hypertension, diabetes, and coronary artery disease substantially increase the risk of stroke. LVH, atrial fibrillation, and acute myocardial infarction are also risk factors for ischemic stroke. Here are the common things that will present to you in a patient suffering from an ischemic stroke. There are some patients will present with all of them, but sometimes they will only have one or two. It really depends on where the blockage is of the blood vessel that's going to cause this presentation. So even if there's no facial droop or numbness, but when you ask the patient their first name and they look at you and say, "banana peel," that's probably a sign that something's going on. The main thing that we should assess quickly when we have a suspected ischemic stroke is first and foremost the FAST ED. Facial droop, arm drift, speech changes, time, eye deviation, and denial, and it ain't just a river. We also want to check blood sugar to make sure that it's not a diabetic issue that's causing the symptoms, and it's a pretty easy thing for us to rule out quickly. Is there anything that we can do to make this patient better on scene? No, there isn't. So what we need to do is get off scene quickly. Here's what the mom says. The information that we are obtaining from the patient helps us determine the patient destination, whether it's a primary stroke center or a comprehensive stroke center. These patients will usually present with hypertension. This is a compensatory mechanism for the body. The easiest way to explain this as a reference, I'm hoping everybody's seen the original Willy Wonka, is where Augustus Gloop falls into the chocolate and then gets sucked up into the tube. Well, Augustus is the clot or obstruction. The tube is your vessel. Your body increases the body's blood pressure in an attempt to push the clot through. If that happens, that's a good thing, but it's called a TIA. The patient still needs to get transported because of the increased reoccurrence problem. Here's our scorecard, like playing mini golf. Any score greater than or equal to 4 is going to need to be transported to a comprehensive stroke center. The higher the score, the more complex the stroke is and the more parts of the brain are involved. So it means that it increases the probability of needing neurosurgery. So the first things first. The patient has a positive stroke screen exam. Our next step is the length of time must be less than 24 hours, and then call the stroke alert. After we call the stroke alert, we calculate the score. If they meet any of the criteria on this slide, it's an automatic score greater than 4 and require a comprehensive stroke center. Here's a list of all the comprehensive stroke centers in our area. Notice that all the trauma centers are also comprehensive stroke centers because they have neurosurgery. Most of our patients are going to qualify for comprehensive stroke centers simply because almost the entire county is taking some sort of blood thinner other than aspirin. Our on-scene time should be very short for these calls. Once we determine that it is a stroke, there's not much that we can do for the patient except get them to the correct facility. What we can do is help them from getting worse. We want to avoid interventions that would decrease cerebral perfusion or increase the metabolic rate. Avoid anything that will increase the clotting or make it worse, like O2 when they don't need it, or warming the body, which increases clotting. Oh, yeah, and get off the scene. Time is brain. Hemorrhagic stroke is when a blood vessel in the brain ruptures, which is what causes the decrease in blood flow to the affected part of the brain. This also has other effects because it increases the intracranial pressure because the blood becomes trapped. So our goal for these patients is to treat the H-bombs that we discussed in PH-TLS: hypoxia, hypercarbia, and hypotension. So the cause could be from trauma or not from trauma. Just gather a good history to see the nature of the illness or the mechanism of injury. Here are the 3 classifications for hemorrhagic strokes. A subdural is usually due to some sort of trauma, and more likely in the elderly due to the brain atrophy. So there's more space for the brain to bounce around. This is why it's always a good reason for Nana to go get evaluated at the hospital, because they have more gradual onset. We're still going to perform the fast ED on these patients. However, they may or may not have a similar presentation. They usually have more confusion, headache, or nausea and vomiting. Subarachnoid. This is the guy who was working out and started to strain and pop. This is a sudden worst headache of my life. They usually go downhill pretty fast, so early recognition of this type and getting off scene is your best course for this patient. Once they start seizing or becoming aggressive, they will probably show outward signs of herniation shortly after, so be prepared. Epidural hematomas are bad and progress quickly. This patient is the one who said, "Hold my beer," so he could jump off the roof onto the trampoline into the pool. He hits the trampoline and completely misses the pool and lands on his head. He's knocked out at first, then he wakes up and is acting normal, then becomes unresponsive. Maintain a high index of suspicion with these patients because we can't actually determine which is which in the field. We're just making a best guess and trying to perfuse the brain long enough to get them to the hospital so they can get the blood evacuated. Hopefully we'll have a good outcome, but that depends on us. Here are the same diagnostics that we will be performing on these patients, but make sure you pay close attention to the airway. Once a patient clenches, also called trismus, it will be difficult to maintain their airway. So continually reassess and always have in the back of your mind that you might need to take over the airway. The MOMS is still M4 for suspected CVA. However, if you're going to suspect a hemorrhagic stroke, they'll definitely go to a comprehensive stroke center. But if they sustain trauma, they will probably go to be a trauma alert, which is why, like I mentioned earlier, trauma centers also have neuro. So what are our goals? Get off the scene. Recognize the signs of herniation, such as a blown pupil, non-reactive pupils, seizing, posturing, vital signs that are consistent with Cushing's triad. If we see this, it is bad. Their brain is being smushed out of the back of their skull. All we can do is try to keep their end tidal between 30 and 35 to help reduce the pressure building up in their skull and elevate the stretcher to 30 degrees and drive fast. What exactly is a seizure? Well, seizures result from excessive and disorderly neuron discharge in the cerebral cortex. The clinical manifestation of seizures depends on the area of the brain that's involved, and it can range from subtle behavioral changes to dramatic tonic-clonic motor activity. So there's lots of different presentations for seizure, so make sure you get a good history. Most of the time, on our arrival, the patient has stopped the seizure-like activity. We have to maintain a high index of suspicion and not fall into that trap of, "Oh, this is stupid." We will perform our assessment and narrow down the differential diagnosis. All we can do is go off the information that we were given by witnesses. What are we looking for? Well, that's going to be, is the patient incontinent? Are they postictal, confused? We also need to have a high index of suspicion that they might have a second seizure after we make contact, so be prepared. We are also very lucky now to have Versed that we can use intranasally. Make sure we get a blood sugar and a 12 lead just to rule out things, since it is also altered mental status. M14 is our protocol for patients with seizures. Getting O2 on them is always a good idea. It will help clear up their head, but most of us know that each time we try to do that, they keep pulling off the nasal cannula. Just remember that patients stop breathing when they have a seizure, and if the patient starts to seize again, if you don't have IV access, you can go ahead and give Versed intranasally. So try to get that IV access early in case they do seize again. Try to narrow down what the cause of the seizure was, if you can, by getting a good history. Whether they have a history of seizures, or if it's a child with a febrile seizure, or even a tumor. There's lots of reasons someone could have had a seizure. Here are the pitfalls. Basically, like we have discussed this whole CME, just follow the systematic approach and it will take you to where you need to go. Take all the information and narrow down your differential diagnosis. Well, Thank you for your time. I hope you enjoyed this month's CME. Thank you for your service. And remember, I'm Ross Pinney, and you stay classy, Pinellas.